do you think about the future for immunotherapy for B-cell? And this question by Abdullah.
Is that for me? Excuse me. I think, it's the same story with checkpoint inhibitors. I think we're still trying to figure out how to most effectively implement them. But I think the story with B-cell lymphoma is different because that's really where we're seeing success with CAR T. And I think and many of us are moving toward CAR T and also the bispecific antibodies that Jim just talked about are in clinical trials in B-cell lymphoma and also have been effective. So I'm thinking more in lines of cell-based therapies and bispecific antibodies rather than checkpoint inhibitors in diffuse large B-cell lymphoma.
Thank you very much, Dr. Is Dr. Armitage joining? I think they are waiting for him to join, but for the time being, I will look for any question for T-cell. And that was about the CLL question. No. This question about the large B-cell lymphoma, maybe we'll wait for that. And how many years almost does it take to cure someone with lymphoma in early stage? Maybe Dr. Foss can answer. How many years it will take to cure someone in lymphoma?
I think it depends. It depends on what type of lymphoma we're talking about. I'd be interested in seeing what Jim has to say about that as well. But certainly with low-grade lymphoma, it's a long-term proposition, and we wonder whether we ever cure anybody. With aggressive T-cell lymphomas, for instance, people require upfront chemotherapy and autologous stem cell transplants. So that's at least a year of therapy. Now, because half of those patients are relapsing, we're giving maintenance therapy as well. So I think more in terms of a long-term approach with these patients. So cure is definitely not as easy as it is with Hodgkin's.
Thank you, Dr. Foss. I can see that Dr. James with us. Thank you for joining, Dr. James. Dr. James, there was a question about the BDL1. I can see it here in the chat. So the question is, BDL1 expression markedly increase in diffuse large B cell lymphoma. Do you think, I cannot actually get the, what's he mean by the, maybe he's asking if the BDL1 expression is markedly increased in diffuse large B cell lymphoma.
Well, diffuse large B cell lymphoma is not a disease, but a complicated group of illnesses. And to date, the only place that PD-L1 blockers have exciting data is mediastinal large B-cell lymphoma, a particular subset, which, by the way, is much more like molecularly like Hodgkin lymphoma. So beyond that one example, there's no place that I've seen data or we have had any experience to suggest that it's going to be a very important therapy for most of the patients with diffuse large B-cell lymphoma.
Dr. Foss, thank you, Dr. James. Dr. Foss or Dr. James, one of you, if you can answer the question about allogenic stem cell transplant and T-cell lymphoma. Any take on that?
Sure. We have done extensive allogeneic transplantation in patients with both aggressive T-cell lymphoma and cutaneous T-cell lymphoma with success with graft versus tumor effect. Even in the haplo setting, we've been able to achieve that. The problem is that about 60% of people have a long-term remission, and we're still faced with late relapses, both early and late relapses. So I think we need to start thinking about what kinds of therapies we can administer after transplant. I've had very good luck with post-transplant relapses using brentuximab vedotin as well as donor lymphocytes. So I think certainly allogeneic transplant is a curative modality for many of these patients, but we need to monitor them carefully, and we need to intervene early on if there's evidence of disease recurrence.
Francine, this is Jim. The one time that we would do an allo transplant as part of the initial therapy as an adjuvant is a hepatosplenic T-cell lymphoma in a young patient. Do you agree with that? And would you use it in any other disease, any other subtype up front?
Absolutely. You know, we try to do allo in our gamma delta subtype T-cell lymphomas because the outcomes are so poor. So that is hepatosplenic, and some of these primary cutaneous aggressive cytotoxic T-cell lymphomas also can benefit if you can achieve a remission. But we're also thinking about it in the high risk, high IPI patients with aggressive PTCL, for instance, where we don't think that there's a chance they're going to stay in remission long with autologous transplant. Now that we have some CAR Ts coming in the T-cell lymphoma space, I think that's going to be an alternative, hopefully in the future, to allogeneic transplant. But certainly there are some very advanced stage patients with bad histologies that you might consider transplanting up front.
So excuse me, I'm back. Sorry for the technical issues. I'd like to welcome all the speakers to the podium here. So I would like to continue with the questions. Dr. Voss, you didn't mention anything about NK T-cell lymphomas. I mean, there have been impressive responses to immune checkpoint inhibitors. In your center, I mean, do you see any of these cases? We see a few of these here in Saudi Arabia, and they're challenging cases. So would you like to elaborate on that, please?
Yes, we actually see a fair number of these patients as well. We see a lot of early stage NK T-cell patients that we treat with asparaginase-based chemotherapy and involved field radiotherapy, and they tend to do very well and stay in remission. But we also see the more advanced stage 4 patients who need more aggressive strategies like SMILE or aggressive chemotherapy. I've definitely seen relapsed patients do well with checkpoint inhibitors. And my question to myself is that because the SMILE regimen is really very rigorous and very toxic, whether or not we should be using the checkpoint inhibitors as part of the upfront strategy. I think that would be a study to pursue in the future. But we don't see enough of those stage 4 patients like our colleagues in the Far East to be able to do those kinds of studies. But I really think that's the direction we should be going in.
Thank you. Dr. Armitage, you mentioned, you elaborated on the Keynote 214 study, which showed that there's an advantage in progression-free survival for patients who are treated with pembrolizumab as compared to rituximab vedotin. But certain questions have been raised from this study. First of all, we know that patients who were on rituximab vedotin could not complete 34 or 36 cycles of rituximab vedotin in this study. It was impossible. The other thing is we know that patients with BV monotherapy following relapse after auto can be cured, even if this is a small number. But we don't have any data on the ability of these immune checkpoint inhibitors as monotherapy to cure patients with relapsed refractory Hodgkin's disease. Do you agree with that?
Yes, the study you mentioned is controversial. The data is the data, but there are a number of reasons to be cautious about, and I tried to say that when I spoke, that if that was all there was and it turns out to be true, then the PD-1 inhibitor would be better, but we'll learn more as time passes. And I agree with you that it's not clear that right now, at least, that a single agent PD-1 blocking antibodies are going to cure any significant number of patients with relapsed refractory Hodgkin lymphoma, although the responses are very good. And there are some patients who do well for a very long time. I have, in fact, the very first person I treated that way years ago is still well. So it's possible to have a long survival, but that's certainly not what happens to most patients.
So another question for Dr. Voss. So we've seen promising results with immune checkpoint inhibitors in mycosis fungoides and Sézary syndrome. You elaborated on a study that was published in the JCO. And are you running any studies comparing, looking at combinations of these immune checkpoint inhibitors with other novel agents, such as brentuximab vedotin or the CCR4 antibodies or mogamulizumab?
So, excuse me, so there are studies now combining checkpoint inhibitors, and a lot of that focus is on combining them with HDAC inhibitors and demethylating agents and agents like pralatrexate. So I think there's certainly a lot of possibilities. I would like to see some evidence-based studies. So I would like to see some evidence of in vitro synergy for some of those combinations, because as you know, there aren't that many aggressive T-cell lymphoma patients or cutaneous T-cell patients out there. So I think we have to think carefully about what studies we undertake. But there's other checkpoint inhibitors that are now coming into the clinic. There's a TIGIT antibody that's about to enter clinical trials. I think that will be interesting. So I think we'll be starting to rationally be able to layer on these therapies. I'm interested in looking at the microenvironment as well, and perhaps combining other checkpoint inhibitors with agents that might modulate populations of cells. Like, you know, there's the combination of mogamulizumab and checkpoint inhibitors that's being looked at. So I think we need to think further and also look at rational combinations of these.
Okay, thank you very much for our outstanding speakers. I'm sorry, but our time is up. We have to go on with the next session. Thank you very much for attending. I will look forward to seeing you at some point live as this pandemic slowly resides. Thank you very much.
Thank you.
So I would like to, it's my honor now and pleasure to present the chair of the satellite presentation that's following. Dr. Firas Al-Faih is a consultant in hematology, stem cell transplantation and cellular therapy, and director of the Unrelated Donor Registry Program at King Faisal Hospital and Research Center in Riyadh. He is the president of the Saudi Society for Blood Disorders. Dear Dr. Al-Faih, the microphone is yours. Thank you.
Thank you, Prof. John. Thank you to Dr. James and Dr. Francine for the elegant talks. So it's my great honor to introduce Dr. Carol Moreno. Dr. Carol Moreno, she's a hematologist from Barcelona, Spain. She has a deep interest in chronic lymphocytic leukemia. She is a board member of European Research Initiative for CLL. She has been the leading author for many publications. Dr. Moreno, she will be talking about redefining CLL standard of care in 2021, which is Janssen satellite talk. I would like to welcome the almost 4,000 attendees who are still with us. So Dr. Carol, please accept our apology for the delay, and the floor is yours.
Thank you very much. So hello to everyone, and first of all I would like to thank the organizers for inviting me to give this lecture at the annual Saudi Hematology Congress meeting. So thank you. And I will try to give you an overview of the therapeutic strategies that we have available for patients with CLL in 2021. These are my disclosures. And to start with, I would like to show you that this diagram, in which you can see that there are several factors that need to take into consideration when advising CLL therapy. And these factors are host-related factors, disease-related factors, safety associated with the different therapeutic approaches, and also in the relapsed refractory setting, the prior therapies. Among them, the most important factors that need to be considered when deciding therapy in an individual patient with CLL are age and comorbidities, also the presence of high-risk cytogenetics, namely P53 aberrations, the IGHV mutational status, and of course, in terms of the safety, we need to take into consideration whether the patient has some prior cardiac disorders or impairment of renal function, which can be relevant even in the era of targeted therapies. And in the relapsed refractory setting, still wild type and number of prior lines of therapy, and particularly response to therapy and its duration, is very relevant. Having said that, you know that all patients with CLL have very heterogeneous disease. And because of that, we need to have, apart from the clinical stages, some prognostic markers that allow us to predict the clinical evolution of the patients. And apart from the clinical stages, the two prognostic factors that are well consolidated in CLL, and that if you check at the PubMed and you look for prognostic scores, such as those performed by the German CLL study group, the CLLIP, the Barcelona Moreno, from David Ostier, Rossi in USA, you can see that in all these prognostic scores, there are two common factors, and these are the two: the IGHV mutational status and the presence of p53 aberrations. And this is because we know for many years now that patients with p53 aberrations have poorer outcome compared to those patients without these p53 aberrations. And looking at this data that was published many years ago, I would like just to highlight that the presence of TP53 aberrations may be reflected by the presence of the deletion of the 17p, but that there are a number of patients that can present mutations in the p53 gene. So there is 23% of the patients, if we take a look only at the patients with p53 aberrations, that can have mutations in the p53 gene with no deletion of 17p. Because of that, it's very important to check, when we check in the test for patients, to look at the deletion of 17p, and if it is negative, to sequence the gene in order to detect whether the patient has a p53 mutation. And this is very, very important because we know now from many years ago that patients who have p53 aberrations, no matter if they have deletion or p53 mutation, they do the worse in terms of overall survival than others. But apart from that, it's very important that you take into consideration that if you perform the NGS for p53, you're able to detect lower small clones of p53, even below 10%. And I would like to show you this study from the European Research Initiative on CLL, which clearly show that no matter what is the size of the p53 clone, if you have a patient with p53 mutations, even in a lower range between less than 10%, you can see clearly that this matters and that these patients, no matter what is the size of the clone, do worse than those patients who have wild-type p53 gene. Apart from that, another prognostic marker that I mentioned, that I will go very briefly, is the IGHV mutational status. We learned this many years ago, more than 20 years ago. We know that there are two clinical forms of this disease: those patients who have mutated IGHV genes versus those who have unmutated. We know that according to the mutational status of the immunoglobulin genes, the biological behavior of the CLL cells is different, as you can see here in this slide. But what is more important is that the patients who have unmutated IGHV genes, these patients tend to accumulate more genetic lesions which confer poor prognosis, such as p53 aberrations and also Notch1 mutations, F3B1 mutations, and these patients have higher predisposition to suffer clonal evolution. In the end, we are talking about a population who have poorer outcome in terms of overall survival, while those patients who have mutated IGHV genes are those patients who have a good prognosis and usually are associated with good prognostic cytogenetics, such as, for example, deletion of 13q. Because of that, so we need to perform this test not only at the time of diagnosis, but just before starting therapy, because apart from being prognostic markers, these markers also allow to predict the response to some specific regimens. So this is very, very, very important. We don't need to perform these prognostic markers at the diagnosis, but they are necessary to test before starting therapy. And why is that? Because these are response predictors that will allow us to design specific therapeutic strategies for these patients. Here we have a summary of the response predictors that have been published over the last few years in CLL. So here there are two important points: that the response predictors are treatment modality dependent, and that among all these prognostic response predictors that you can see in this slide, the only fully consolidated response predictors that we need to perform before starting therapy are these two. P53 aberrations, because they clearly are associated with failure to chemoimmunotherapy, and we know that even in the context of targeted therapies, these patients do worse than those without these P53 aberrations, and patients with a mutated IGHV genes clearly have a shorter duration of the response to chemoimmunotherapy. Other response predictors have been published, and you can see that there are many papers with complex karyotype, deletion of 11q, the mutations of the BTK, notch mutations. These can be additional response predictors that can allow us to design specific therapeutic strategies, but please note that the only fully consolidated response predictors are these two, which are highlighted in red. In the recent years, well, I would say in the last decade, almost the last decade, so we have had a great improvement in the CLL therapy thanks to the introduction of targeted therapies, particularly the introduction of inhibitors of the B-cell receptor signaling pathway, and also the inhibitors of BCL2. And probably the main characteristic of these targeted therapies is that these drugs act via P53 independent. And this is very relevant because I have already mentioned that patients who have P53 abnormalities do not take any benefit from chemoimmunotherapy. And for these patients, we need to treat these patients with targeted therapies. But what is the best therapeutic option for these patients? So if we take a look at the different randomized trials, comparing targeted therapies versus chemoimmunotherapy in the front line. So sorry, I don't know, but this has disappeared when uploaded into the system. I don't know whether you can see this column. Unfortunately, I cannot see it, and it was in my original slide. So anyway, so what you can see here is that all targeted therapies, BTK inhibitors, have been compared with chemoimmunotherapy in the frontline setting. Ibrutinib, the second generation of BTK inhibitors, such as acalabrutinib, also BCL2 inhibitors, such as venetoclax, have been all compared versus chemoimmunotherapy. And all these trials clearly show that targeted therapies are superior to chemoimmunotherapy in the frontline setting, particularly in terms of progression-free survival. And there is only one study which shows only a benefit in overall survival, which is the trial that was performed in the younger population. I will go later to this trial. So if we take a look at the treatment algorithm that we are using in Sant Pau Hospital in 2021, and also if you take a look also at the NCCN guidelines updated in last February, also the ESMO guidelines already published, I would like now to focus on the fact that the patients who have active symptomatic disease according to IWCLL criteria are these patients who have criteria to start therapy. If we take a look at the treatment-naive patients, age, comorbidities, and physical status needs to be taken into account. And when we have patients who have P53 abnormalities, the therapeutic options will be targeted therapies. And as you can see here, in Sant Pau Hospital, our first option is Ibrutinib, which is already stated in most of the guidelines. And the second option will be a time-limited therapy with venetoclax-obinutuzumab, keeping idelalisib, which is an inhibitor of PI3 kinase, the isoform delta, for later lines because of the safety profile of this therapeutic approach. But let's have a look at how we can manage these patients with P53 aberrations. So here we have a kind of summary in which you can see what is the efficacy of the different inhibitors of B-cell receptor signaling pathway in P53 patients, with P53 alterations in patients with CLL. You can see here these are the results. Long-term follow-up in the relapsed refractory setting, in which you can see that the median progression-free survival was more than 3 years, 40 months in patients receiving Ibrutinib in the relapsed refractory setting. If we take a look at the dialysis rituximab, the median progression-free survival was considerably shorter, 18 months. And in terms of the second generation of BTK inhibitors, acalabrutinib, you can see here that the median has not been reached, although I must say that this trial have a very short follow-up, just only less than 3 years, and because of that, we cannot see the median progression-free survival in patients receiving acalabrutinib. If we take a look at the long-term follow-up data with ibrutinib, which is the only drug that can give us this kind of information, you can see here that in the phase 2 study performed at the NIH with a long-term follow-up, 5 year, looking only at patients with p53 aberrations, we can see what is the response of these p53 aberrant patients, in which you can see that the progression-free survival is quite good, is near 80% at 5 years, and the overall survival, most of the patients are alive after 5 years in the frontline setting. Obviously, in the relapsed refractory setting, patients do worse than in the frontline setting. But a very good results when we compare this, obviously, with chemoimmunotherapy. And unfortunately, we cannot compare these results with other time-limited therapies such as venetoclax or with a second generation of BTK inhibitors, because we still have shorter follow-up with all the other targeted therapies. Additionally, at ASH last year, it was presented a long-term efficacy of ibrutinib in the frontline setting in patients only with p53 aberrations, and it was performed a pool analysis from 4 different clinical trials, recruiting only patients in the frontline setting, in which you can see that is according to the data that we have seen from the NIH, at 4 years, near 80% of the patients are free of the disease in this very high-risk population, and that patients are alive, near 90% of the patients are alive at 4 years. So ibrutinib, as single agent given continuously in the frontline setting in patients with p53 aberrations, probably is the therapeutic choice, and this is one of the reasons why in our hospital this is the first option for these patients. If we take a look at the BCL2 inhibitors, venetoclax, you know that in the development, it was approved first as monotherapy, but now it has been approved in combination with anti-CD20 monoclonal antibodies. And if we take a look at the time-limited therapy with the combination of venetoclax-obinutuzumab in the frontline setting, we can observe with a relatively short follow-up, just only 3 years, we can observe how patients who have p53 aberrations, when stopping the combination with venetoclax and obinutuzumab, we can observe how these patients are likely to have to progress. So because of that, time-limited therapy is now being debated in the scientific community, whether just time-limited therapy for a year will be enough for this high-risk population. Additionally, if we take a look at the efficacy of BCL2 inhibitors in patients with p53 aberrations, we can observe that in terms of the eradicating minimal residual disease, the patients who have high genomic complexity, which are the patients who have p53 aberrations, half of them still have high levels of MRD after 2 years of venetoclax rituximab, which probably is giving us the information that time-limited therapy for these patients, although is desirable, is still, so we don't have what is the optimal time-limited therapy for this population. Let's have a look at the management of elderly patients with comorbidities or those with comorbidities. And if we take a look at the first trial that was performed many years ago, this is the final analysis of this trial published almost 2 years ago, the leukemia, which showed that ibrutinib was superior to chlorambucil in the frontline setting in patients older than 65, and there was a benefit not only in terms of progression-free survival, but also in terms of overall survival. And this benefit was observed independent of the high-risk cytogenetics, such as deletion of 11q or the presence of unmutated IGHV genes. This trial led to the approval of ibrutinib in the frontline setting, but of course, this was a comparison between ibrutinib versus chlorambucil and not chemoimmunotherapy. Because of that, many trials after that were published, already, this has been already published, and we have some data in terms of randomized trials comparing ibrutinib-based therapy versus chemoimmunotherapy, mainly chlorambucil, obinutuzumab, or bendamustine rituximab in elderly population or those with comorbidities. We have the Illuminate trial and the Alliance trial. I will show you very briefly the results, but this is just to remind you that ibrutinib in combination with obinutuzumab in the frontline setting improved progression-free survival compared to chlorambucil obinutuzumab in this elderly population, including patients with high risk. As you can see here, the benefit in patients with high risk was clearly superior. Progression-free survival at 3 years, 72% versus 12% in the patients receiving chlorambucil obinutuzumab. Additionally, when we take a look at the different prognostic markers that I mentioned at the beginning of my talk, you can see that there is a clear benefit in patients, whether they are unmutated or mutated, whether they have mutated or mutated IGHV genes compared to chemoimmunotherapy. Another trial that compared also ibrutinib-based therapy versus chemoimmunotherapy versus bendamustine rituximab in elderly population was the Alliance trial. The 3 years follow-up was published in New England Journal of Medicine in 2018. And you can see here that there is a clear benefit in terms of progression-free survival of patients receiving ibrutinib, either alone or in combination with rituximab versus bendamustine rituximab. And this benefit was observed in all different prognostic subgroups, including complex karyotype and mutated high-risk cytogenetics. And of course, in terms of the IGHV mutational status, we couldn't see any differences in terms of progression-free survival at 2 years between those who received bendamustine rituximab versus those receiving ibrutinib. Although with longer follow-up, we are seeing how these curves have started to separate it in between, and probably we will see a benefit with longer follow-up of this trial, even in patients with mutated IGHV genes. Other drugs, targeted therapies already available in this elderly population is acalabrutinib. This is a second generation of a BTK inhibitor, which is more selective than ibrutinib to BTK. And this is a trial that was performed in the frontline setting in elderly population with or without obinutuzumab versus chlorambucil obinutuzumab. You can see that the median follow-up is short, it's less than 3 years. This study was already published at Lancet and led to the approval of acalabrutinib in the frontline setting with or without obinutuzumab. You can see clearly significant benefit in terms of progression-free survival in those receiving acalabrutinib versus those receiving chlorambucil obinutuzumab. Of course, this trial was not designed to look at differences between those receiving acalabrutinib alone versus those receiving acalabrutinib with obinutuzumab. And because of that, the approval of this drug has been with or without obinutuzumab in this elderly population. The time-limited therapy available for the elderly population is the venetoclax in combination with obinutuzumab given for 6 cycles, and then venetoclax for a year. And you can see, well, this trial was already published and led to the significant benefit in terms of progression-free survival in patients receiving venetoclax-obinutuzumab. But probably the most important consideration with this time-limited therapy is whether this is an optimal therapeutic approach for patients with high risk. And as you can see here in this sub-analysis, according to the IGHV mutational status and also according to the P53 aberrations, what is quite clear is that only with less than 4 years of follow-up with this trial, we can see how patients who have mutated IGHV genes or those who have P53 aberrations, when stopping therapy, we can see that there is a decline in the PFS curve. Probably, reflecting that these are the high-risk patients who are likely to progress when stopping this therapy. And this is something that we need to take into consideration when deciding therapy in the frontline setting. What about the safety profile of all these drugs? So I would like now to mention a few words between ibrutinib and acalabrutinib. I already mentioned acalabrutinib is a more selective BTK inhibitor, and as such, it was expected that the safety profile will be more favorable compared to ibrutinib. Here we have not the most frequent adverse events, but those who are, the adverse events which are of clinical interest in terms of the BTK inhibitors. You can see fatigue, rash, neutropenia, hypertension, pneumonia, atrial fibrillation, bleeding, arthralgias and myalgias in patients receiving ibrutinib. And in acalabrutinib, we can see most of these adverse events again, but particularly is very, very frequent, the headache, which is characteristic from the acalabrutinib, and it doesn't appear in patients receiving ibrutinib, but we can also see some cardiovascular events, although it seems that the frequency, it can be lower. So I will discuss now this later on. If we take a look at the long-term follow-up in patients receiving ibrutinib and looking at the adverse events, we can observe in this elderly population with 5 years of follow-up that most of the adverse events are low-grade adverse events 1 or 2, and that most of them occur during the first 6 months, even during the first year. But after that, we can observe that most of these adverse events decline over time, except I would say hypertension. This is very important because, I mean, we are talking about a continuous therapy with ibrutinib as single agent, and because of that, it's very important to know that these adverse events decline over time. And this is what we are seeing, at least this is my clinical experience with the drug. If we take a look at the adverse events of clinical interest, so clinicians, we are concerned about, right? Major bleeding, atrial fibrillation, hypertension, and we can also observe that, again, most of these adverse events, particularly major bleeding, is very uncommon. It occurs around, it has been published around 4% of the patients, so this is more or less my experience in the clinic. Also, atrial fibrillation, although most of the atrial fibrillation are grade 1 and 2 and can be managed, but the atrial fibrillation can appear around between 6 and 8% in the clinical trials, a little bit high in the real world setting. And hypertension, we can observe that there is a continuous frequency of patients who develop hypertension, although this is not really, is very easily to manage in the clinic, and no problems are, well, I haven't had any problem regarding hypertension generally, because they can be easily treated with drugs, and hypertension can be under control. I would like to mention that if we take a look at the trials, so in most of the trials, you cannot see that even in more than 50% of the patients in the ibrutinib trials, patients were receiving anticoagulants and also antiplatelet agents. So here I would like to mention that it's clear that the dual antiplatelet therapy is contraindicated in patients receiving ibrutinib, but we can treat patients with ibrutinib either with antiplatelet agents, such as aspirin, for example, and also anticoagulants, particularly direct anticoagulants, DOAC, direct oral anticoagulants, which are allowed and can be given at the same time with ibrutinib, and no major concerns can occur. If we take a look at them in terms of infections, I would like to highlight the fact that ibrutinib has shown somehow a partial restoration of the immune function, particularly the humoral immune function, and this is correlated with the decrease in the infection rate that we observed over time in patients receiving ibrutinib, particularly in the frontline setting. I would say that in the relapsed refractory setting, we obviously need to take into consideration prior lines of therapy, and maybe depending on the prior lines of therapy, if the patient received chemoimmunotherapy, to treat these patients with sometimes some prophylactic antibiotics. But in terms of the treatment-naive patients, so I can say that there is no major concerns about infection, and most of the infections decrease over time after a year, and they are associated with somehow a partial restoration of the immune function. This is well stated because we know that because of ibrutinib not only inhibits BTK, but also inhibits ITK, which is involved, the enzyme which is involved in the T helper differentiation. And because of that, we know that Ibrutinib led to a T helper 1 skew repertoire, which can be responsible, have been associated somehow with the efficacy of the drug about restoring the immune system and also being able to control the tumor growth. This is one of the papers that was published many years ago by the group of John Baird. And after that, there is some data regarding how Ibrutinib can restore immune cell populations. And this is a very busy slide, but I would like just to show you that there are a lot of the studies just showing that there is a partial restoration of not only on the numbers of T cells, the CD4 and CD8 T cells, but also in terms of the macrophages, monocytes, and obviously the function or the activation of the T cells seems to be restored, and that can help also to control the disease, not only through the BTK inhibition, but also the ITK inhibition may play a role of this. And this is one of an hypothesis that probably the partial restoration of immune system probably may lead to lower infections, a better outcome over time in patients in which we are not really eradicating the disease, as we are seeing in patients receiving Ibrutinib. Actually, this is just a brief summary just to show you that there is not only an impact on malignant B cells, but also there is an impact on the immune system. And because the immunosurveillance and the restoration of the immune B and T cell populations may have an effect, an indirect effect that has been clearly associated with particularly with Ibrutinib. In terms of adverse events, I would like just to show you that there are some secondary, the next generation of BTK inhibitors, such as acalabrutinib, has been already approved. And this is the data that I showed you, the frontline setting, the only study that we have in the frontline setting. So, I mean, it seems that there is a more favorable safety profile in terms of atrial fibrillation, hypertension, and major bleeding when compared probably with Ibrutinib, although still there is a discontinuation due to adverse events, which is not negligible. 11% and 9% of the patients discontinue the drug. And still, I would say that we still need to have real-world data with this drug, a longer follow-up in order to have solid conclusions in terms of these adverse events. So probably we will see in the near future a randomized study which has been performed, Ibrutinib versus acalabrutinib, that probably will give us some information in terms of the safety profile of the both drugs, and whether one has a more favorable safety profile compared to another in terms of cardiovascular adverse events. And because of that, if we take a look at the Sant Pau algorithm, and we have already discussed all these therapeutic strategies in elderly population or those with major comorbidities, BTK inhibitors is an option. We still don't have acalabrutinib approved in Spain, and Ibrutinib is the first option for this elderly population, or venetoclax time-limited therapy can be an option, but particularly in patients who have mutated GHB genes. So we can discuss that in the Q&A live session after that. How do we manage young CLL patients with no comorbidities? So there is only one study, which is the Coca-Cream trial, that compared Ibrutinib given in combination with rituximab, Ibrutinib at the standard doses, and rituximab given for 6 cycles, and then after that, Ibrutinib was given as a continuous therapy versus FCR in the patients younger than 70 with a good performance status. Please be aware that there are no patients with P53 with deletion of C19P included, because the patients were randomized to chemoimmunotherapy. And this trial, with less than 3 years of follow-up, showed a clear benefit of not only progression-free survival, but importantly, a benefit in overall survival in patients receiving Ibrutinib versus FCR. it's very important that the benefit of this drug was particularly observed in patients with unmutated IGHV genes, while in those patients with mutated, no significant differences were observed. And because of that, still chemoimmunotherapy can be considered an option in patients younger than 70 with mutated IGHV genes. In terms of safety profile, I would like just to add, we have seen the safety profile in the elderly population, but I would like just to mention that if we take a look at the safety profile in a younger population, in terms of the adverse events of clinical interest, we can observe that the frequencies are quite low as we compare the frequencies observed in elderly population.
And Dr. Moreno, 1 minute, please.
Sorry? Sorry?
1 minute.
Yes, I'm finished.
Do you hear me?
Yes.
Thank
So
you.
in elderly population, according to the IGHV mutational status, so we need to consider in those mutated, still chemoimmunotherapy can be an option, and in those unmutated, the ibrutinib will be the first therapeutic choice. Having said that, I would like just to summarize that the patient-related factors, disease-related factors, and prior therapies need to be taken into consideration to select the most appropriate therapy in CLL in 2021. That overall targeted therapies, BTK inhibitors, and venetoclax-based regimens have shown to be superior to chemoimmunotherapy in the treatment-naive and in the relapsed refractory setting, that the P53 aberrations are still negative outcome predictors for BTK inhibitors and venetoclax-based regimen, but the long-term follow-up data with ibrutinib as single agent led that ibrutinib will be the therapeutic choice for patients with P53 aberrations in the frontline setting. Combination of different small molecules with or without anti-CD20 monoclonal antibodies, such as, for example, the combination of ibrutinib and venetoclax, will probably replace single agents in the near future. T-cell therapy still is an option, but for highly selected cases refractory to targeted therapies, and treatment modalities should be chosen based on a risk-oriented treatment plan from the initial to second and subsequent lines of therapy, because still we need to determine what is the best sequential therapy for patients with CLL. And of course, trials and real-life data are needed in order to improve our knowledge about how to treat the patients with CLL in the future. And thank you very much. This is all.
Thank you, Prof. Moreno, for an elegant talk. Due to time constraint, I will take 2 questions. So the first question is, are we expecting fixed duration in near future for ibrutinib and CLL?
Yeah, yes, but probably this will be in combination with venetoclax. I mean, there are some trials, because of the sake of time, I couldn't show more information, but there are some trials which have already combined ibrutinib plus venetoclax, even for a time-limited therapy for a year or 2 years, which are showing, and we have seen some data attached, which are showing a very good results in terms of eradication of the disease. And probably we will be able to stop therapy. Time-limited therapy will be possible with ibrutinib, but always in combination with BCL2 inhibitors.
Okay. The second question I have is regarding the addition of anti-CD20. So why it's more prominent in acalabrutinib, not in ibrutinib?
Yeah, that's a very good question. So I mean, we haven't seen any benefit of the addition of anti-CD20 monoclonal antibody in patients receiving ibrutinib. This has been shown in several trials, and because of that, ibrutinib as single agent is the standard of care for patients. But in terms of acalabrutinib, it seems that this drug, because of the more selectivity to BTK, doesn't interfere the DTC that is part of the function of the anti-CD20 monoclonal antibodies. It's one of the pathways of the anti-CD20 monoclonal antibodies, and because of that, probably because there is no impairment of the ADCC, because of that, probably acalabrutinib has more benefit in terms of adding obinutuzumab, as we have seen in the trial already published by Sharman. But I would like to say, I mean, it's the main problem is that we have also Ibrutinib in combination with venetoclax-obinutuzumab, which has been already approved by FDA and EMA because of the Illuminate trial. And what we are seeing with these anti-CD20 monoclonal antibodies is that we are able to increase the rate of undetectable minimal residual disease, but these trials were not designed to stop therapy at any time. So unfortunately, the addition of anti-CD20 monoclonal antibody, while it can be, it can improve the quality of the response, it has no impact in terms of stopping therapy in these patients. It's true that we are seeing that there is a superior progression-free survival in the ASCENT trial in patients receiving obinutuzumab, but the differences are not statistically significant, and the trial was not designed to see differences. But this is probably because of the ADDC impairment with Ibrutinib, while we are not seeing this with Acalabrutinib. Yeah, very important question.
Thank you so much. So by this, we will conclude this presentation. Thank you, Professor Caro Moreno, for your time and very nice presentation.